doctor Gehrke nos va a hablar de vástagos anatómicos y de lo que pueden aportar en la cirugía de cadera en el ámbito del fémur.
Thank you. In my second talk, to be honest, I'm heavily biased because I'm going to talk about a stem which I designed together with Helmut Link, who is the owner of the Waldemar Link company. So there's a strong bias. Keep this in your mind, but I try to do my best to convince you now. I'm going to talk about the anatomically uncemented stem. The anatomical concept is already proven. For example, in the cemented stems. The SP2 stem, which is in the market now since almost 25, 30 years, gives us fantastic results proven in the registries and in the Swedish registry, for example. The Lubinus SP2 stem, the cemented stem, is considered as the best stem in the whole registry. What's about the straight concept, the non-anatomic concept? Here you see some examples of traditional straight stems. I'd like to introduce you three now. First of all of you know the Zweimuller alloclassic stem, which was designed in 1979, almost 40 years ago. They changed the design a little bit. And the philosophy here, the fixation philosophy here is, as you all know, the distal, the diaphyseal fixation. The outcome, and especially the survival rates of the Zweimuller alloclassic stem is fantastic. But if you look into the literature a little bit deeper, then you came to the conclusion that this stem has some weaknesses, especially a very high incidence of thigh pain. Then the Italians are the Sportorno came in the late 80s and designed the Sportorno stem, the CLS stem, which has a completely different fixation philosophy, the proximal metaphyseal press fit, also with fantastic results. And last but not least, very often used in Europe, the Corail stem, you all know it, which has also fantastic survival rates, and especially in the Norwegian registry, it seems to be the best, and in the National Joint Registry, the best performing uncemented stem. But what are the issues with straight stems? There's one issue which is really concerning. It's the high incidence of periprosthetic fractures, because the straight stems are designed like a splitting wedge. And if they migrate a little bit, they split the femur like a splitting wedge that you use if you do some kind of timber work. Here, for example, it splits the bone completely, and you have revised it. So many, many examples. This is an example of mine. I did this patient. I implanted a Sportorno stem in a patient with severe Parkinson's disease. It was a mistake of mine. Today I use more cemented stems if I have a patient with severe Parkinson's disease. And here, after a stair fall, the stem splits the whole femur. And again, the registry showed this, that's a significantly higher rate of periprosthetic fractures. Why do we need an anatomical stem? Because of the wholly anatomical structure, which is, of course, the greater trochanter, because of the insertion of the gluteal muscles which are stabilizing the stem, the leg in the standing position. As you all know, I call it this muscle always the engine of the hip. And the problem is, if you like to introduce a straight stem, you have to harm, in some cases, the greater trochanter and the gluteus medius. So there could result a gluteal insufficiency after straight stems. They have potential risks of damage of the muscles and damage of the greater trochanter. And you can reduce the risk if you use anatomically stems or, for example, stems that you have heard just from Luigi. There's one paper, it's a quite old paper from Robert Bourne, which showed an incidence of gluteal insufficiency, and this is for the patient a catastrophe. He has a limping, a Trendelenburg limping, and he will never be satisfied with the new hip. The incidence of gluteal insufficiency after a total hip replacement, 4 to 22%. And there is a more recent